Hi, everyone. Welcome back. It's my real great pleasure to welcome you all to our symposium on digital mental health and early intervention for psychosis. Thank you so much for joining us, and particularly to those who are coming to listen to us at very unsociable hours across the globe. We're incredibly grateful. And also massive thanks to the IEPA Organising Committee and conference organisers for allowing us to present our symposium today. My name is Charlotte Gerandson, and I'm a research fellow at the Institute of Psychiatry, Psychology and Neuroscience and the ESRC Centre for Society and Mental Health at King's College London, UK. I guess very briefly, and as I know you'll be super excited to hear from our speakers today, but I guess the premise of this session essentially is that with the growth of the internet, social media, mobile phones and other digital technologies, our world has profoundly changed in many ways. And I guess particularly over the last 18 months with COVID-19, we've all become even more dependent on technology and experienced the vast array of opportunities and challenges it presents in our personal lives and our professional lives. And there's really very sobering data to suggest that even in
Unfortunately, it looks like Charlotte is having some Wi-Fi difficulties. It happens. So she might maybe make her comments towards the end rather than do it now. It looks like she's rebooting. So rather than trying to fill in for her, what I suggest is that we start the talks, and then when she's able to come back, we listen from her. So the first speaker tonight is Inez Myin-Germeys, and Inez is a professor at the Center of Contextual Psychiatry at the Department of Neuroscience in the University in Leuven in Belgium. And she's going to talk to us about a large study that they're doing there. So without further ado, please welcome Inez Myin-Germeys.
Hi, my name is Inez Myin-Germeys, and it's a pleasure to present to you the work we have been doing at KU Leuven at the Center for Contextual Psychiatry on acceptance and commitment therapy in daily life for people in the early phases of psychosis. So I will talk about a study that we've done, which is called the INTERACT study, and it's a study on a blended care intervention where we combine face-to-face sessions with an ecological momentary intervention using acceptance and commitment therapy. So basically, within the INTERACT study, we provide 8 sessions of face-to-face acceptance and commitment therapy to our participants. And then this intervention is increased or is extended with an app, which is called ACT-DL, Acceptance and Commitment Therapy in Daily Life. And basically the goal of the app is to give people the opportunity to practice what they've learned in therapy session in their daily life in different ways. So first of all, 8 times per day for 3 days in a row. After each face-to-face session, people fill out a beep questionnaire. So they get a beep, and then they have certain questions about their current mental state, their emotions, and it's really a sort of mindfulness exercise, being aware of the here and now. Next to that, people get either an ACT exercise or an ACT metaphor. They both relate to what people have been working on in the therapy session. in addition to that, people also have the opportunity to go to the exercises themselves at different moments to practice what they've learned in therapy. So this is a trial, the INTERACT trial is a multi-center trial in different centers in Flanders and the Netherlands. And basically we compare the ACT-DL with treatment as usual. Can consist of either a non-structured intervention or therapy or a structured CBT for psychosis. And the INTERACT study has been done in close collaboration with Ulrich Reininghaus, who is currently in Mannheim. So basically, we investigated whether ACT-DL would be helpful in people in the early phases of psychosis. So we included 148 people with an at-risk mental state for psychosis or a first episode of psychosis. And it was about 50-50 of each of these groups. Baseline assessment, including experience sampling research to measure daily life processes as well as the CARMs. And then 71 of the individuals were randomized into the active condition, which was acceptance and commitment in daily life. And then we had post-assessment and 6 and 12-month follow-up, and psychological distress was the primary outcome measure. So let's first look at feasibility. So when we look at the 8 face-to-face sessions, we found that overall 62% of the individuals participated in all sessions, all 8. Then we had 9 individuals, so 13%, who did not participate in any session. And then we had 18 individuals who participated in 1 to 7 sessions. So the average number of sessions was 6 out of 8. This is the face-to-face therapy. Then we look at, so if we then look at the actual number of sessions, so you see this is the distribution with most sessions, with most people actually being involved or participating in all sessions. And this is work of Evelyn van Aubel, who was the PhD student, one of the PhD students on this project. Now, when we then look at compliance with the app, we see that the adherence is relatively low. So if we look at the 3 days per week, where we have 8 beeps per day, that means that on average you could have 24 beeps, or in total you could have 24 beeps, and on average people only respond to 6 beeps per week, which is really a low adherence with the app. However, as I said, we also had ACT exercises, and we had morning and evening questionnaires where people would fill out things. So when we really look at the number of interactions with the app in total per week, you will see that the number is still quite substantial. So we see that on average people have about 15 interactions with the app, and that number remains kind of similar over the different weeks. So in that sense, although you could say that adherence is quite low with 25%, if you look at the actual number of interactions per week, it's quite substantial. Then when we look at how people, what the acceptabilities of the app, how people experience the app, we see that in general, people are quite, think it's quite helpful and useful. So they found the app in itself, in general, useful to use. And now I have to go a bit closer to the screen because the so it also helped them to become more aware of their feelings. However, when we then specifically asked about the burden, we also see that the app was increasing the burden. So meaning that both the number of beeps and the length of the questionnaire was considered as burdensome. In general, when we asked people whether they would do the ACT exercises in the future, they were positive about it. So in general, there's quite a positive feeling about the app. Although people clearly also say that there is a burden. Then when we look at what people actually use when they work with the app, when they are involved in the therapy, we ask them like what specific tools do they use, and we see, and sorry, this is a bit, this looks a bit strange, but yeah, this is what happens sometimes with PowerPoint. So what we see is that basically people used the 40% used both the app, the workbook, and did exercises on their own. 40% used the app and the workbook, and 11% used the app, only the app. So basically, if we combine these numbers, we see that about 90% of the people in the trial who were actually randomized in this arm made use of the app. We also did some qualitative research, and we inquired about what did people report on in terms of strengths and limitations. And so when we look at the ACT-DL app specifically, they felt that the app is connected to the sessions. Also, they indicate that they want to keep using the app after the study, and that the app is helping to integrate ACT principles in their daily life. On the negative side, they said there were technical problems with the app, and some people, so this is interesting, some people say the app is closely connected to the sessions, and others said that that was not the case, so definitely there needs to be some improvement there. And some people had, in general, a negative feeling about the app. When we look at the exercises, people liked that they had a free choice of exercises they did, and that the app was helpful to remember the exercises. But some people found the exercises not so useful and said that it's not so easy to do the exercises at work. And then when we look specifically at the ESM questionnaire, many people said that it really increased their awareness of feelings, thoughts, and symptoms, and they had a positive attitude towards the questions. However, sometimes most people said that there were too many beeps, that it took too long to fill out, and that the timing of the beeps was sometimes inconvenient. So, okay, this is more on the sort of feasibility and acceptability of the method, showing that people are willing to do it, that they're also capable of doing it, but also some limitations that need some improvement. Now let's look at the outcome of the trial. Was this trial actually also effective? So first of all, as I said, we looked at psychotic distress as measured with the CARMS as our primary outcome measure. And what we see in this graph is that when we compare pre to post, we see that in both groups of treatment as usual only and the experimental condition of acting daily life, that both groups had a significant decrease in psychotic distress, which was maintained up at 6 and 12-month follow-up. However, you can see that the change did not differ between the two conditions. So both conditions were equally effective in reducing psychotic distress. So in that sense, ACT-DL did not outperform treatment as usual. However, we also looked at some other outcome measures, which were our secondary outcome measures. So first of all, we looked at the number of symptoms as measured with the BPRS. So we looked at severity of overall psychopathology, of affective symptoms, and with overall psychopathology and affective symptoms, we found that at 6-month follow-up, there was a larger improvement in ACT-L compared to treatment as usual, but that was only at 6 months and did not sustain over time. We found no differences in psychotic distress, in manic symptoms or positive symptoms. However, when we then look at negative symptoms, we see quite a different outcome, which is really an interesting finding to us. So what we see in negative symptoms is that ACT-DL really outperformed treatment as usual consisting of both CBT for psychosis as well as non-structured psychotherapies. So what we see is basically that the negative symptoms increase in the group that was treated, was in the treatment as usual condition, whereas in the ACT-L condition, it decreased further over time, and the effects were mainly visible at 6 and 12-month follow-up. And this was clear when we measured this both with the BPRS severity of negative symptoms as well as the BNSS severity of negative symptoms. Then we also looked at functioning. So we used the SFS to look at self-reported social functioning. And here again, we see a similar picture. So we see that with treatment as usual, social functioning increases a little bit over time, but this effect is much larger in the ACT-L group already at post and then also at follow-up 6 months. It's not significant anymore at month 12, but you see that there's an increasing line of still improvement of social functioning. Also in global functioning, as measured with the SOFAS, you see a clear improvement in global functioning in both conditions, but the increase in or the improvement in global functioning is definitely larger in the ACT-L condition compared to the treatment as usual condition. And so these are, of course, really interesting findings. We know that both negative symptoms and social functioning or functioning in general are amongst the hardest to treat. It's a very intriguing finding that we find improvement in this. Of course, these were our secondary measures, not our secondary outcomes, not our primary outcomes. So this should be replicated, but it's very promising. It's also promising that you see that it keeps improving over time. And this is something that we have seen in previous research as well, using EMIs, where apparently this gradual change in behavior or patterns of behavior over time has an increasing effect. And that's also what we see here in this study. So currently, we are now working on the IMPACT study, which is a follow-up of INTERACT, where we first of all are optimizing the app for the clinic. So we listened to what both clinicians and patients said about the app, so that it actually is more closely linked to the clinical workflow. We are preparing official trainers' manuals, and we're running an implementation pilot, while also really developing or thinking about medical device regulation and developing a business model, because I think, yeah, we basically have two goals right now. One is to replicate this finding, of the effect, but also to work towards implementation in the clinic. So that brings me to my conclusion. So first of all, what we showed is that ACT-DL as a blended care intervention where we add an ecological momentary intervention to a face-to-face therapy is feasible for people in the early stages of psychosis. We also noticed that the absolute compliance with the app is low, yet the number of interactions is still substantial, which also sort of indicates that maybe we need to think in a different way about compliance when we work with apps and when we look at real life interactions, that maybe not every interaction that is possible is relevant, but it's really the overall number of interactions that counts. And then we also found that ACT-DL is not improving psychotic distress, which was our primary outcome, and that was mainly due to the fact that treatment as usual was equally effective in improving psychotic distress, yet ACT-DL outperformed treatment as usual, which consisted of both CBT for psychosis as well as non-structured psychotherapy, in improving both negative symptoms and functioning, both of them being symptoms that are really hard to treat. So really showing a potential of this digital mobile health solution for people in the early stages of psychosis. And with that, I'd like to end my talk. I'd like to thank all the people in the Center for Contextual Psychiatry and all the different centers that were involved in this work, including the people in Amsterdam with Lieve de Haan, and in Parnassia with Mark van der Gaag as collaborators on this project. Thank you very much for your attention.
Great, thank you so much, Inez, for a fantastic presentation, and thank you, Lucia, for sharing whilst technology failed me and my internet went. Huge apologies for that. I hope you're enjoying the talk so far. Please do get involved. Should you wish to ask a question, please use the ask the question button under the live stream, and do submit these at any time throughout the presentation, and they'll be addressed at the end of the session in the live Q&A. And do use the chat function as well next to the live stream to make any comments and interact with the other attendees. And finally, if you're using Twitter or other social media, don't forget to use the conference hashtag IEPA 2021 virtual. Great. So I'm going to introduce our next speaker, who is Mario Alvarez Jimenez, who is a professor of digital mental health at the University of Melbourne and director of Origin Digital at Origin, the National Centre of Excellence in Youth Mental Health. Over the past 10 years, Mario has founded and consolidated Origin Digital as a large world-leading innovation and research centre with 78 researchers and professionals from 15 different disciplines and more than 30 research projects, in which the team develop, evaluate and implement digital interventions that dovetail with the national and international network of youth mental health services to really enhance their accessibility, their long-term impact and cost effectiveness. So please welcome Mario. Thank you.
So it's a pleasure to be here today, to be part of this symposium and to be able to share with you the data from the Horizons trial, one of the recent clinical trials that we have finished in young people with psychosis. So I'm going to jump straight into it. This is a quote that I particularly like from Ron Kessler. This is one of the most widely cited mental health researchers in the world, and he said that we spent an enormous amount of effort in research and in clinical care on getting people well, and most of the time that works pretty well. but we spent almost no effort in keeping people well with enormous losses and costs. And this is certainly the case for young people with psychosis, where we can typically provide specialized support for up to 24 to 36 months of time. We have quite a bit of evidence from different clinical trials conducted across countries and mental health systems that these services do indeed improve outcomes. But after that, young people are discharged to community adult mental health services, no specialized services, and we've got evidence as well that many young people won't find those services as appropriate to their needs. And many young people will fall through the cracks of the system, not getting any support at all, which will place them at risk of relapse and therefore at risk of losing the benefits of early intervention. So, and indeed, there's been now a number of clinical trials comparing the 2 versus 5 years of specialized support with mixed findings. So we took a slightly different approach, and we thought, can we provide digital support at the point of discharge from these services that is specifically designed to maintain the psychosocial gains of early intervention services for psychosis? The question, of course, was what kind of framework or intervention should we use in order to engage young people for long enough, but also to promote long-term functional and social recovery? And we thought that the self-determination theory of motivation provided actually a useful framework on which to base these interventions. According to this theory, many of you will be familiarized with it. If we're able to promote and to engage the 3 basic psychological needs of self-competence, relatedness, or having close and meaningful connections with others, but also autonomy, being able to lead your own life and make your own decisions, that can foster engagement with both the online intervention, but also with life activities, which will increase intrinsic motivation, and over time that will lead to improved social functioning through increased performance and persistence, but also enhanced well-being. But we thought we're not quite targeting those domains directly through our current interventions. So we thought, how about if we give personal strengths more of a central role in therapy, and then we can help young people identify their personal strengths, but then give them, or we can teach them how to use the personal strengths in different environments to cope with the stress, to enhance positive emotions and well-being, and to also connect with others and have meaningful connections. We can also integrate therapeutically consistent or theoretically consistent therapeutic interventions such as mindfulness and self-compassion, which we know enhance positive emotions and well-being, but also promote and foster healthy emotional regulation strategies. And then we can also incorporate evidence-based interventions for psychosis, early psychosis, particularly interventions designed or targeting vocational recovery and relapse prevention. If we do this, these interventions and domains are likely to be synergistic, reinforcing each other, and be also conducive of promoting long-term social and functional recovery. And then we thought, how about if we include all of this or embed all of this into a supportive, safe and meaningful online social network? Then we can provide an entirely new therapeutic environment that is motivating and is specifically designed to promote long-term functional and social recovery. We think of it as a transitional social network that young people can use in the path to recovery. And this is how MOST was created, which is a highly flexible and constantly evolving model, which essentially integrates peer-to-peer and social networking that is being specifically designed to foster meaningful, safe connections amongst young people, expert support provided by clinicians and vocational workers, peer support provided by young people with lived experience, but also evidence-based therapeutic models that are delivered in attractive ways. And you can see there on the left the evidence-based interventions that the Horizons platform included. A lot of work and effort has gone into the development of MOST. Over 85 researchers and professionals from 15 different disciplines have been working on different versions of MOST over the past 11 years, and these include comic writers, comic developers, I should say, also professional writers and novelists working together with experts in human-computer interaction, clinicians, researchers, and young people. And indeed, young people are at the core of everything we do. We have partnered up with them from the inception of Horizons and MOST, and we've done over 1,000 consultations, which have informed and shaped the entire direction of the intervention and the therapeutic model as well. And this is what MOST, the third version of MOST, which powered Horizons and the clinical trial that from which I'm going to show the results today, look like. On the left, you can see that Horizons help young people identify their personal strengths and also show them in the central screen how to use them in different environments. For example, we had hundreds of strategies that help young people use their personal strengths, for example, using creativity to deal with social anxiety. And as young people did that, they will go up in levels, which included gamification aspects. We also included comics through which we, I suppose, illustrate therapeutic concepts. Here on the left, you can see animation in a comic where young people could breathe in and out with the movement of the moon. In the central screen, you can see the therapeutic social network where, in addition to being able to talk to other young people had also individualized therapeutic suggestions based on their preferences and needs. And on the right, you can see the Talk It Out function, which was a problem-solving group where young people could pose problems and they get support from clinicians and other peer workers and other young people in solving those problems following the problem-solving framework. So we just completed a 5-year randomized control trial. We randomized 170 young people in clinical remission, young people with psychosis, to either treatment as usual or treatment as usual plus Horizons for 18 months at the point of discharge from the EPIC program in Melbourne. And these are the results that we found. First of all, we found no safety incidents or adverse events over 5 years. And in terms of engagement, we found that 80% of young people regularly engaged for at least 3 months, and around 50% of young people engaged for 9 months, which from my perspective, from my point of view, I suppose, reinforces or gives value to the potential of this platform to engage young people over a sustained period of time beyond discharge from early intervention services for psychosis. But what about the clinical and psychosocial outcomes? This is the results in social functioning, which was the primary outcome variable of the study. We hypothesized that those young people in the treatment as usual group would experience a deterioration in psychosocial functioning, whereas those young people in the Horizons group will maintain the psychosocial functioning over time. And what we found here is that there were no significant differences between both groups, and both groups started relatively high and remained so over the duration of the study. So how can we interpret this? So these are the baseline psychosocial functioning in the OPUS trial, which is a comparable study that compared 2 versus 5 years of specialized support in young people with psychosis. And as you can see in our study, the psychosocial functioning at baseline was significantly higher than that in the OPUS trial. So how can we interpret this? So it could be that we ended up with a subsample of high functioning individuals due to the inclusion criteria. Particularly, we require for young people to achieve clinical remission for them to be part of the study and to ensure the safety of the social network. It could be that the quality of the background treatment, particularly of the EPIC program, led to higher functioning at baseline, and the EPIC program includes very intensive psychosocial support, including vocational recovery support, but also a very intensive group program. It could be that there's been a number of significant improvements in the post-discharge care in our catchment area with the development of 5 youth mental health services that we manage ourselves, and that they have become the discharge destination for many of our young people, and this could explain the lack of deterioration in psychosocial functioning in the treatment as usual group. It could be that young people need a certain threshold of pattern of engagement in order for them to improve their social functioning. And of course, it could be that we need a totally different treatment approach or modality. I'll come back to that a little bit later. On the other hand, we found that young people in the Horizons group had a 5.95 higher increase in the chances of finding employment and education compared to those young people in the treatment as usual group, which was a significant difference. Just to put this in context again, at baseline, the employment rate in our sample was significantly higher than that in the OPUS trial, and even then we were able to find significant differences. And we also found a dose response effect with those young people in the top 25% of logins having a significantly higher effect size compared to those young people in the bottom 25% of logins, which reinforces the validity of this finding. We also find evidence that Horizons did decrease the level of utilization of emergency services over the course of the study. Particularly, we found twice the rate of hospital admissions due to psychosis in the treatment as usual group compared to the Horizons group. This analysis didn't quite reach the level of statistical significance, but it's worth noting that the statistical power of the analysis was quite low due to low event rates, and the number of young people needed to treat with the Horizons platform in order for us to prevent one hospital admission was 7, which is equivalent to the number of needed to treat in specialized services for them to prevent one hospital admission. But the validity of this finding, I suppose, is also reinforced by the associated and consistent finding that those young people in the treatment as usual group had twice the rate of visits to emergency services compared to those young people in the Horizons group. This analysis did reach the level of statistical significance. And we found that there were a total of 12 repeated visits to emergency services from 7 different participants, all of which happened in the treatment as usual group. And once again, this reinforces the validity of this finding. In terms of negative symptoms, we found that those young people in the Horizons group experienced a significant improvement in negative symptoms from baseline to 12 months compared to the treatment as usual group, which was, however, lost at 18 months follow-up. So in terms of interpreting these findings, Ashok Mala in Canada and his team found improvements in negative symptoms in 5 versus 2 years of specialized support. Similarly, Eric Chen's group found in Hong Kong improvements in negative symptoms in 3 versus 2 years of specialized support, which were, however, lost at 3 years follow-up. So our results are partly consistent with these findings and suggest that Horizons might have a time-limited effect of negative symptoms, or it could be, of course, that this is just simply a chance effect. So we looked into this more carefully, and this is the work of Shona O'Sullivan, a fantastic Irish PhD student from our group. And what we did was to have a look at the patterns of usage of Horizons over the first 6 months of the study, particularly looking at the depth and breadth of engagement with the therapeutic and social components of the platform, and then have a look at the relationship between these patterns of usage and clinical outcomes. And using clustering, we found 3 different groups. One of them was low use, another one was maintained use of the social aspects of the platform but not of the therapeutic components, and another one was maintained use of both the therapeutic and the social aspects of the platform, so including the social network but also therapy content as well. And it's worth noting here that low use doesn't mean lack of use. In fact, those young people in the low use had an average of 12 logins over 6 months. It's just low use compared to the other groups. Then we compared each of these groups in some of the key outcome variables, and we found that those young people in the maintained therapy and social group had a significant improvement in social functioning compared to the other 2 groups. We found a similar pattern of findings with respect to negative symptoms, where those young people in the maintained therapy and social group experienced a significant improvement in negative symptoms compared to those young people in the low usage and maintained social groups, and similar findings as well in general psychopathology, with those young people in the maintained therapy and social group experienced significant improvements compared to the other 2 groups. We then compared those young people in the maintained therapy and social group against those young people in the treatment as usual group, and again we found a similar pattern of findings where those young people which used both aspects of the platform in a consistent way, there are therapeutic and social components, experience significant improvements compared to in social functioning compared to those young people in the treatment as usual group, and similar findings in both negative symptoms and general psychopathology. Of course, these are exploratory analyses. They come from non-randomized comparisons. It could well be that we comparing non-comparable groups, even though we control for baseline differences and also for potential confounders. So we cannot make any causal inferences here, but nonetheless, these are very suggestive findings that are guiding our research and the modifications that we've made to the MOS platform as well and to the Horizon system. So what can we conclude from here? First of all, the Horizons is a safe and engaging platform for young people with psychosis, and a promising approach to deliver sustained support beyond discharge from these services. Also, the Horizons is effective in improving vocational and educational outcomes, which is one of the core aspects of functional recovery, and also reducing utilization of emergency services in young people with psychosis, which is one of the prime targets of early intervention services for psychosis. We also found that sustained engagement with both therapeutic and social elements might be related to its therapeutic impact. But of course, Horizons need to be refined to better address social functioning and other outcomes, which is some of the work that we've been doing at the moment, modifying the platform, but also the moderation models to promote sustained usage of both aspects of the platform.
And this has led to the fourth version of MOS 4.0, which was released in 2020 after 24 months of very intense work on it. We're still improving, obviously, and making it better. It's been driven by 11 years of research, and it's been done, as I was mentioning before, in partnership with young people. Here you can see some of the key features of the latest version of MOST, but some of the key changes are related to the therapeutic content and also the structure of the therapeutic content. We've got now a new feature called Guided Therapeutic Journeys and Tracks, where young people can find different kind of content in different key themes, for example, social anxiety.
Hi everyone, sorry about that. Ran into a few more technical difficulties. The record, we will make sure that Mario's presentation, full presentation, and audio will be available afterwards. So, but please do hang on if you've got any questions. I'm sure Mario will be able to answer those at the end of today's session. So next up, we have Sandra Bucci, who's a NIHR research professor, professor of clinical psychology at the University of Manchester, and honorary consultant clinical psychologist at Greater Manchester Mental Health National Health Service Foundation, as well as co-director of the Complex Trauma and Resilience Research Unit. Sandra leads an amazing program of research focused on developing pioneering digital care pathways and using digital remote monitoring and intervention methods to improve detection and treatment of severe mental health problems. So thank you so much, Sandra. We look forward to your talk.
Hi, I'm Sandra Bucci, Professor of Clinical Psychology based at the University of Manchester, and I'm going to be reporting the trial results of the ACTASIS-2 study, which is a CBT-informed self-management app for people with early psychosis. The study was funded by the Medical Research Council and supported by the University of Manchester, Greater Manchester Mental Health NHS Foundation Trust, and Pennine Care NHS Foundation Trust. I'd like to acknowledge the team that were working on this trial, all of whom the pictures you can see here. And I'd also like to acknowledge and thank our independent trial steering committee and data monitoring ethics committee that provided independent oversight of the trial. Professor Max Birchwood, Dr. Amy Hardy, Stephanie Allen, and Dr. Bunny Cundill. Okay, so back in 2014, we started co-designing and developing the ActAssist app. So the ActAssist app is a fully automated standalone digital health intervention. It's not a blended therapy and it's not a medical device. And the app targets relapse indicators in early psychosis as listed here on the screen. The way the app works is that it alerts people 3 times a day, 6 days a week for 12 weeks. And when the app emits an alarm, a user selects a target area that they're feeling distressed by. If they're not feeling distressed in that moment, then an encouraging message is sent. If a person does indicate distress at any given moment, they work through a series of question-answer exchanges, and depending on the appraisal selected against a target domain, they're given a targeted cognitive or behavioural strategy. So the idea is to introduce CBT ideas and deliver cognitive or behavioural strategies in response to distressing experiences in small chunks, but regularly in the flow of daily life. It also consists of a multimedia toolkit that can be accessed at any time, which comprises a range of resources that we have co-produced with service users and with clinicians throughout. You can also visualise how distressing experiences have fluctuated over a given period of time. And ActAssist from the outset has been co-produced since 2014, and details of the process that we've followed has been published in a recent paper, as you can see here. So in our first proof of concept trial, we compared the ActAssist app with a symptom monitoring app called ClinTouch. And we demonstrated the safety, feasibility, and acceptability of the ActAssist app by showing high rates of acceptability. There were no reported serious adverse reactions or treatment withdrawals. Our feasibility parameters were met. And although not powered for a treatment effect, we found improvements in psychotic and mood symptoms at the end of treatment when compared against an active control comparator with large effect sizes. These results led to further funding from the Medical Research Council, who funded a powered trial, which we creatively called the ActAssist 2 trial. Importantly, we chose to put ActAssist up against an active comparator, and this was for 3 reasons. Firstly, the comparator, which is a symptom monitoring app called ClinTouch, has a very similar look and feel to the ActAssist app, and so it controls for the non-specifics of having and using a phone in daily life and being involved in a trial. 2, given it has a similar look and feel and functionality to ActAssist, we could isolate whether there was a specific effect of the intervention, i.e., do the CBT ideas and strategies seem to be particularly important and have a particularly more potent effect than symptom monitoring alone? And thirdly, it's important to compare your intervention to standard NHS care. So we wanted to put ActAssist up against what we thought would be treatment as usual in the future, which we anticipate will involve some form of digital remote monitoring or digital self-management. So in this way, we were trying to future-proof what we were testing. This is an intensive comparator. So in the comparison group, using the ClinTouch app, people are alerted 3 times a day, 6 days a week, over 12 weeks, and people monitor psychotic and mood symptoms. So our test in this trial was, does ActAssist confer added benefit over and above this comparator, which we know already from a previous trial shows benefit in people with a first episode of psychosis. We had a pre-specified analysis plan that permitted the ActAssist app to be updated over the course of the trial, while the comparator remained static, to ensure it was not technologically obsolete by the end of the trial period. 3 years is a long time in the tech world. So we wanted to try and also future-proof the platform that we developed over the course of the trial. Participants were within 5 years of a first episode of psychosis and were largely recruited through early intervention for psychosis teams across the northwest of England. These are our eligibility criteria, which was primarily meeting ICD-10 criteria for a schizophrenia spectrum diagnosis, or meeting early intervention for psychosis entry criteria, and so on. Okay, so this is the study design. Once people were recruited, consented, and screened for meeting our eligibility criteria, they completed a baseline assessment, and there were 2 follow-up time points, one at post-treatment, which is our primary endpoint for our test of efficacy for this trial, and 24 weeks post-randomization. Following the baseline assessment, where we captured a range of clinical and functional measures, participants were randomized using sealed envelope randomization software within 2 days on a 1-to-1 allocation, stratified by service, to either receive the ActAssist app plus treatment as usual, or the ClinTouch symptom monitoring app plus treatment as usual. And like I said, this allows us to control for the non-specifics of having and using a smartphone, and because we think digital monitoring will become part of routine treatment in the future. We had 3 predefined version updates to the ActAssist app over the course of the recruitment window. And following randomization, the researcher visited the participant, informed them of their allocation, and conducted a single onboarding session where the researcher helped the participants to set up the app either on their own phone or on a loaned handset. They set the participant up on the University of Manchester server that hosted the data, helped the user familiarise themselves with both the handset where needed and the app that they received. For the ActAssist app, participants were invited to set up to 3 goals to work on during the intervention window. And the alert schedule started the next day, where participants in both conditions then received 3 alerts 6 days a week for the 12-week intervention period. A researcher worker made weekly to monthly contact to check in about any technical difficulties. And we also measured the Digital Therapeutic Alliance. So this stems back from the work we did in our proof of concept trial, where people reported relational qualities with the ActAssist app. And so we developed, led by Professor Catherine Berry at Manchester, a measure of the Digital Therapeutic Alliance. And we measured this in the ActAssist 2 trial at week 4 and week 8 of the intervention window. So in addition to giving people a handset if they needed it, we covered the data network charges for all participants for the 12-week intervention period. And we told people to go about and use the phone as they normally would. At the 12-week assessment, a blind assessor again administered a range of clinical and functional measures. They disabled the app and collected the handset if it was a borrowed handset. Participants in both group and staff who had referred people to the trial were also invited to complete a qualitative exit interview. We repeated the measures again at 24 weeks. We debriefed people about the study, and we asked the participants if they'd like to take part in future related research. Alongside this process, we carried out quarterly meetings with our patient and public involvement group, and the trial steering committee had independent oversight of the trial and reviewed all our adverse event data. We administered a range of clinical and functional measures at each of the 3 assessment time points, including measures of symptoms, functioning, quality of life, as well as measures of substance misuse and service use. So most assessments at each time point were completed in 1 visit, but there was a substantial number that took place over more than 1 visit, where we had to go back a couple of times, sometimes 3 times in some cases, to complete the assessments. Reasons for some additional visits that we had to conduct with a few people were usually tech-related visits. So sometimes people had lost their charger or lost the plug, so we had to replace that. Some people thought there were some technical glitches, like an app alert issue or a general handset issue, so that prompted an extra visit from the research worker to check that out. One person reported problems hearing the alert, so we had an extra visit, for example, to the participant to troubleshoot that. We had a huge number of standard operating procedures in place, and it ranged from things like how to reimburse participants, how we would manage unblindings, how we were going to operationalize and measure adverse events, through to remote working in the latter stages whilst COVID-19 pandemic took place. Okay, here's the consort diagram. So of the 343 people that were referred to the trial, we lost around a third of people prior to eligibility checks. This was for various reasons. Some people refused. We lost contact with some people. 52 people declined to take part for research-related reasons. 25 people declined to take part for app-related reasons. So of the 213 people that we assessed as eligible, we randomized our target sample, in fact, just over our target sample in our anticipated recruitment window. And only 3 people were not set up on an app. We also followed up 87% of people at both the 12 and 24-week follow-up time point. And we had 2 withdrawals from the study, both at the 24-week follow-up period. They didn't want to complete that follow-up. We randomized on average 6.8 participants per month, and this was over a 21-month recruitment window across 2 mental health trusts, as I said, in the northwest of England. In terms of handsets, we purchased 89 handsets to give out to people. So 47 of these were returned at the end of the trial. The majority were intact, but a significant proportion were returned not intact. We replaced handsets on 10 occasions, and we reinstalled the app on handsets on 10 occasions. Having to return a handset did not negatively affect our follow-up rate though. So I suppose one of the attitudes we came across was people saying, well, if you have to return the phone, they may not complete the follow-up because people will want to keep the phone. But that actually didn't negatively affect our follow-up rate. And there were some, in cases where a handset was not returned, many of these times we didn't know. We either couldn't get hold of people at both follow-up time points. And there was a report of 1 person in the trial who sold the phone. Okay, so here are the demographic characteristics of both groups, and the demographics of both groups were largely similar. So majority of participants were referred from early intervention services. The mean age was 29 years, and it was a mostly white male sample, and most participants owned a smartphone. The majority were single. They'd completed secondary or tertiary education, were receiving disability support, and were living with parents. Okay, so this is the headline finding. As you can see in this graph, based on our primary outcome, which was the PANSS total score at 12 weeks, and this was selected because we saw a large effect size on this measure in the pilot trial. On average, everyone improved over time, but using the ActAssist app did not confer added benefit over and above our symptom monitoring comparator. And there were no differential effects across all the measures. This was surprising because although we know that effect sizes are inflated in pilot trials, the effect size we observed in our pilot trial using the same design were large. So we're in the process of analysing the qualitative interviews because what is apparent from that work is people liked using the ActAssist app more so than they reported using the symptom monitoring app because it gave them something back. So we wanted to tease that out a bit more to understand the data in a more nuanced way. So how did people engage while they were in the trial? So these 2 graphs show the difference between groups in daily engagement over the course of the trial. So this includes both scheduled alerts, those 3 prompts a day that people received, but in the case of ActAssist, you could self-initiate use, so you weren't limited to engage in the app based on an alert or a prompt. You could look at it whenever you wanted. So each horizontal line across the y-axis is a participant, and each data point along the x-axis represents a response by a participant. So the presence of a dot means the participant responded at least once that day. And you can see here that the ActAssist participants have slightly greater coverage over the grid. So it seems that they engaged on a daily basis more often, although there's no statistical or inferential statistics that have been conducted here. So this is purely descriptive and observing the data in this way. So were ActAssist participants any more likely to drop out sooner from the intervention period? So this graph shows the difference in attrition between the two groups. And attrition here in this case is defined as the number of days from recruitment to the final data point submitted by a person. The dash indicates the median days to attrition. So there's two things to note here. One, it looks like at least half of the participants were retained until fairly late on in the trial, so around the 70-day-ish mark. And attrition for the ACT-Assist group appears a little slower. So the red line is above the blue line, for example, throughout. We had 7 unblindings in the trial, and in all cases, we were able to arrange for another blind assessor to complete the follow-up assessments. So all assessments were conducted blind, and we had a rigorous blinding procedure that we used in the trial. We recorded adverse events. Again, we had a rigorous standard operating procedure to record and report adverse events. And what we did was separate out whether an event was related to the hardware, the software, or to the clinical procedures. So we recorded 19 serious adverse events for 10 people, 9 adverse reactions for 9 people, and 67 adverse events for 49 people. There were no serious adverse reactions in response to using either of the apps. So the themes of the adverse events were things like a family or partner disagreement or violence in 5 cases. There was non-life-threatening self-harm recorded, that was in 13 instances. Behaviour that was a precursor to actual self-harm. So for example, someone standing on the edge of a drop, we have reported as an adverse event. Deterioration in symptoms that required follow-up with the clinical team. So for example, people reporting experiencing command hallucinations or suicidal thoughts, but not acting on them, or visits to A&E that were non-life-threatening, but were visits to A&E nonetheless. And in terms of the adverse reactions, 2 people found talking about psychosis upsetting as part of the assessments, and we had to contact the care team to follow up. So this was recorded as an adverse reaction to the trial procedure. For 2 people, the app made them focus negatively on their mental health difficulties. So we recorded this as an adverse reaction. And 3 people reported finding the alerts intrusive or felt that the app fed into some technology-related fears or beliefs. So these were recorded as adverse reactions, but not serious as they were not life-threatening. So the conclusions. ACT-Assist is one of a range of digital remote monitoring and digital health interventions, along with ClinTouch and other digital health interventions that produce some clinical benefit. But automated, isolated CBT strategies where there's no human support in this trial does not confer added benefit over and above digital symptom monitoring alone. Qualitative findings show that people like using the ACT-Assist app seemingly more so than symptom monitoring because people say it gives them something back. We're in the process of needing to fine-tune the system. So what we're looking at doing next is developing prediction models for relapse that can help us then devise and develop more personalised, targeted intervention strategies. So taking into account more this precision medicine approach and building on the just-in-time adaptive intervention idea. And of course, implementation of and uptake of these technologies is a really important aspect of the future work going forward. Thank you. I'd just like to thank all the participants and the staff and the trusts and the research workers, the funders, and our expert reference group who supported the study. Thank you.
Fantastic. Thank you so much, Sandra, for a really fascinating presentation. So our final speaker is Lucia Valmaggia, who is reader in clinical psychology and digital mental health and head of the virtual reality lab at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. Here, Lucia and her team conduct innovative clinical studies to evaluate virtual reality assisted assessments and treatments as well as experimental studies using virtual reality to explore the effects of adverse life experiences on the appraisal of social situations. So please welcome Lucia. Thanks so much.
Thank you, Charlotte, for organizing this great symposium. I'm here to talk to you about the use of virtual reality therapy for psychosis, and I'm going to use a feasibility study as an example of how this can be used in clinical practice. I got nothing to declare. We use virtual reality in research and in clinical practice by immersing people in virtual worlds. So by wearing a headset, you can be immersed in a virtual reality world, and that enables us to assess symptoms as they occur, both in terms of cognitive symptoms like concentration or attention, as well as assessing symptoms, for example, anxiety or paranoia or hearing voices. And what is also the beauty of virtual reality is that it bringing reality into a consultation room or into the lab enables us to help the person who is experiencing symptoms to guide them in real time in coping with those symptoms differently. We have a large lab at the Institute of Psychiatry where we look at different things. So we have studies going on looking at the mechanisms of the onset and maintenance of mental health problems and physical health as well, up to a point. We have some studies looking at treatment, prevention, and training. And I'm going to talk to you today about a study that we did looking at treatment. This was a study done by Dr. Leila Jamel as part of her doctoral in clinical psychology. And we wanted to see if we could implement the use of a virtual reality environment and treatment that we are developing in a lab into a first episode team in South London. So just a bit of background, we know that people with psychosis unfortunately often experience difficulties in social situations, even after remission. And we also know that virtual reality can be effective in dealing with those, as well as cost effective. We recently reviewed how many studies were particularly looking at functional impairments in psychosis, and we found 58 studies, which I will admit were more than we thought we would find. And interestingly, half of them were published in the last 4 years. So this is really a booming field at the moment. That's partly due to the fact that the head-mounted display have become more portable and much more affordable, as well as that the programming has become more affordable as well. So the main finding was that virtual reality is effective in improving social function impairments in psychosis. However, we also found that the social functioning that had been looked at was quite narrow in scope and mostly in lab environments. There was a lack of randomized controlled trials. There was very few longitudinal studies, and there was a lack of standardized interventions. So what we set out to do is to see whether we could develop a standardized intervention and whether that was appropriate, feasible, and acceptable to people who experienced social impairments after a first episode of psychosis. And also, we wanted to see how many people do we need to recruit in order to have enough of them finishing the therapy. So is it something people want to engage with? And what resources are needed? Because this is important in terms of if you want to implement a new intervention, you need to know what is needed in real life to implement it. And secondarily, we also wanted to look whether it changed, of course, the symptoms of the people involved. So the assessment we wanted to test to see whether they were okay to be completed by service user undergoing the therapy. You can see them here. Because we had only 11 participants, we're not expecting to see major changes, and I'll come back to this now. But it's also important that we focus on individual goal setting. So these are goals that are set by the person themselves about what they would like to be able to do at the end of therapy that they are not able to do at the beginning of therapy. So this is really what they want to change. And because of the therapy was aiming at improving social impairments, most of those were around things that they could do in social settings, like, for example, going out again, or attending parties, or socialize with friends. The therapy protocol was based on cognitive behavioral therapy and was formulation based, so was very much aiming not at having one size fits all, to personalize the treatment to the person that was attending the therapy. So session 1 and 2 were used to get a better idea of what the social difficulties of the person were, also to familiarize themselves with the virtual reality equipment and the different environments, to together set goals for the therapy, and if needed to, talk about how the gains during the therapy could be translated to real life in the form of homework. Session 3 to 8 were based on the formulation of the person. We would then develop formal, what we call cognitive and behavioral strategies in the session. So those are really things that you can do together to change the way you respond to a situation, in this case, a social situation. And we use the virtual reality environments, which we have the same for everybody, to help the person develop these new ways of coping with an environment that they found difficult to cope with. And then again, importantly, we made for each person homework, if you like, or we set goals of what they could do between sessions to help them translate what they'd learned in virtual reality into real life. And then the last 2 sessions were to consolidate what they had learned in the first few sessions, and to do relapse prevention and repeat the measures. This is the screen that the therapist sees when they deliver the therapy, and they have the control in choosing out of 8 different interactions that the person can be exposed to, and also in manipulating things like, for example, how hard the laughter is in the environment, or how loud the sound is in the environment. And all of these was developed together with people with lived experience of social difficulties and paranoia and a first episode of psychosis. And you will see that it's quite cartoony. This is something we started developing back in 2015. We now have different settings and different avatars, but you will have to bear with what this looks like at the time. And here you can see an example of somebody using this.
So they kind of like ignored me. So, hey, what's happening? How's it going? Okay. So they like laughed at me. Okay, so this is just really awkward. Everyone, it feels real. You talk to them and they ignore you. It's quite embarrassing.
Okay, I'll take you out.
Okay. Thanks. It feels real, like, it feels like I was going up to these people and trying to open a conversation, and like they'd have a funny reaction to me, or I heard someone say strange when I was talking, or they turned and laughed.
If you felt that it was difficult for you to cope when people were laughing, then we could make the laugh very little to start, and then as you practice, go up and up and up until there are a lot of people laughing. So that you get used to a situation which probably will never happen, but that prepares you for real life, where it will be less. Did you hear any positive comments?
Yeah, but I kind of ignored them because I thought, well, I think they said he's such a nice guy, but I was thinking like they don't know me, so they don't know if I'm a nice guy. But it's funny.
And it's funny because we have half or mouth, some are positive and some are negative.
Oh my God.
And what we have found is people that find it more difficult in this kind of situation notice all the negative comments, and people who find it very easy to go in this situation are more tuned in the positive comments. So what I would encourage you to do the next time is try to also pay attention to the positive comments.
I think that if I use this technology, it would make it a lot easier in real life to go into similar situations, because I've already been there before.
And I would like to thank Anthony for taking part to this documentary, which is, I should just show you some abstracts of a longer video. And Anthony is somebody with lived experience of psychosis who is very passionate about reducing the stigma around psychosis. So coming back to the feasibility study, so we looked on the, we screened possible 44 cases, and the first 17 that we approached were approached as well, and then the other ones we just never approached them because we reached the number that we wanted, which was 11. 4 declined to participate, 2 DNA'd, and 11 agreed to participate, so the conversion rate was 64. And in terms of completing, 82 completed or partially completed the therapy. The partially completed, unfortunately, was due to COVID. So we had to finish with some of the therapies online rather than face-to-face. 1 only completed the assessment and then decided not to take part anymore, and 2 dropped out. It was quite a representative sample for us. So the majority, unfortunately, was unemployed. Majority was non-white. The majority was male and younger age, which is what you would expect in the area that we serve. In terms of feasibility and acceptability, as I said, the 11 participants, we were able to recruit them. 64% was the conversion rate, so how many people we approached and how many consented to participate. So it's good to remember if you want to do a study or if you want to implement this in clinical practice. Of course, not everybody will accept it as a treatment. 82% of those who accepted it, though, engaged with it and stayed until the end. And that's quite good in terms of adherence to treatment or engagement with treatment. And this is despite COVID, as I said. In terms of therapist time, training and supervision, 1 therapist worked 1 to 2 days a week for 8 months, supervised once a week, and it's about 15 hours for each participant for 10 sessions. So you have to take into account, like any other therapy, that you need to allow time for supervision and training. Important in terms of implementation, room availability is, in a lab, you can book your lab and you have time and a reserved room. Unfortunately, in a place like a clinic, it's often difficult to get a room. Wi-Fi often doesn't work. So if you're planning to develop anything, make sure it's not Wi-Fi dependent or internet dependent, but they can run standalone. And it can be difficult to maintain and storage equipment on site. So make sure you have something that is portable. Very few or no unwanted effects were reported. We measured this with the scale developed by Byrne et al. And however, there were some people who experienced the symptoms that they experienced outside or that they experienced when they're psychotic in the VR environment. And they mentioned how important it was that there was a person there that could contain them and they could discuss this with. In terms of post-therapy assessment, so again, remember, this is a very small sample, so we can't say anything about effectiveness, but we just wanted to make sure, people didn't get worse because of it. And we used a measure called reliable change. You can look it up if you're interested, but it's used for case studies. And what we found is that there was a reduction of scores for all participants in almost all the measures, and also that the reliable change was indeed the case for quite a few of the participants, especially with regard to social anxiety and improving social functioning. And as I said in the beginning, we were very keen on having individual goal setting so that the person could identify what for them was important that would change, compared to before starting the therapy. And we were pleased that 6 completely achieved their goal and 2 partly achieved them. So we were pleased with that outcome. In terms of service user experiences, the more positive one mentioned how it helped them to think what they wanted to do, not just in the moment, but much more how they could overcome the distress and the physical symptoms that they were experiencing in that moment to achieve their goals. Also, the fact that the VR therapy was easier to engage with and do than just facing somebody and talking about your problems, which sometimes can be difficult to do and also emotionally quite draining. However, there were also people who said that the VR didn't add much for them, that they much more benefit from the talking parts of the therapy. And also that somebody was reminded of the virtual reality in a real-time situation, and that was distressing for them. I'd like to finish by acknowledging the expert by experience who helped us develop the virtual reality environments that we use. We always collaborate with people with deep experience to develop everything, and also the people who took part. My colleagues, especially Jerome Di Pietro, is the VR developer, and the institutes that pay for our work. And I'd like to thank you very much for your attention.
This is the place we lose our minds. Hold me down. Hold me down.
Fantastic. Thank you so much, Lucia, for a brilliant presentation. It's been really great to hear the wide range of uses of digital technologies that have been employed to kind of improve clinical and functional outcomes among individuals with psychosis. We have a couple of questions. I guess first off, Mario, I don't know if your presentation right at the very end on the last slide, the audio went a bit funny, and I don't know if you'd be happy to just give a brief sort of summary or conclusions of the MOST trial, if that would be all right, just to fill in that gap.
Yes, I can do that, Charlotte. So it's just the last slide on the conclusions. Is that the one that you went? Yes, I can remember. But basically, the conclusions are that from our perspective, Horizons appears to be an engaging intervention for young people with first episode psychosis. So we think that is, I suppose, a feasible way of providing sustainable support for young people at the point of discharge from first episode psychosis services. And the other conclusions are that the intervention appears to be also effective in improving vocational recovery, which is a core aspect of functional recovery, and also reducing utilization of emergency services, which is one of the core aims of first episode psychosis services themselves, but also that utilizing the platform in specific ways, particularly engaging with both social and with therapeutic components, appears to be related to its therapeutic effect, and it might improve social functioning as well.
Great, thank you so much. Sorry to put you on the spot, and just to reiterate, we will make sure that the full audio and presentation is published online, so you will be able to see those when they're uploaded. I do actually have a question for you, Mario, from Anthony Pelosi at Glasgow. He asks whether you could give more details about what treatment as usual looked like in your trial.
Yes, for sure. So treatment as usual, usually in Melbourne, is just discharge to whether they can be like primary care mental health services. These can be, now we've got 5 headspace services in our catchment area. So these are sort of youth-friendly, accessible, youth mental health services. So they provide psychological treatment. They can access psychological treatment weekly or every fortnight. They can also access vocational support. Also, they can see psychiatrists. They can also go, depending on how the young person is traveling, they can go to tertiary mental health services. These are adult mental health services, basically. And some people are referred to those services. Some young people go only 2 GPs, and a significant proportion, to be honest, they don't follow through with the discharge plans unless they go to our headspace services in our catchment area. They sort of fall through the cracks of the system. We've seen that a lot, and they just don't pick up treatment after the intervention. Sometimes they're not motivated either to continue with treatment if they're traveling okay. So I think that's probably the discharge points that we've seen in the study.
Thank you, Mario. And a question for Sandra. Marianne Webb says, thanks, Sandra, for a really interesting talk. I have a few questions. I'd be keen to find out more detail about the study methods. Is there a trial protocol published anywhere that I could read? And I imagine recruitment to a trial of this nature must have been difficult. Could you give some of your top tips recruiting to a trial like this?
Yeah, thanks, Marianne. So the outcome paper will probably be the best reference point, and that should be coming out hopefully in due course, depending on how long these things take. So that will have a more detailed description of the results. We do have a detailed description of the process that we followed, published, that's on the slide there that you'll also be able to see. So that can supplement some of the co-design and team science kind of approach that we've taken to developing the platform and the trial procedures. In terms of the second question, yes, it is definitely the most, I would say, probably difficult aspect of running a trial. And in terms of recruitment, and in terms of top tips, I think one is trials need to be sufficiently staffed and resourced in order to be able to do this kind of work. And it's really tricky because often, you know, with funders, we can be asked to cut costs, or we're trying to shave off costs here and there, and then that makes it really difficult to carry out the work. So where possible, make sure the trial is sufficiently resourced with research workers to be able to do the work. Secondly, is to just be as present as possible in clinical services and teams to do the recruitment. And so that involves things like giving team, presentations to teams, visiting teams where possible to sort of support people with what the trial procedures are and identifying participants that we can contact. And the third thing is, I think it's really important to give something back to services who we're asking to recruit participants from. So, for example, we'd offer training days to people. So, for example, we might run a workshop on, conducting a PANS assessment, for example, or a particular therapeutic approach that someone in the team might have specific expertise in. We'd go and run either a half day or a full day workshop on for the team to try and give something back and be present, and then use that as well as a basis to talk about the trial and what we're aiming to do with the trial. So I think they're important things to do that can really help facilitate that sort of recruitment and engagement with the process and the project. And feeding things back, so giving results back as and when they come in. So, for example, if you've got a nested qualitative study, go back to the team and tell them what the outcome of that is, and perhaps how you've incorporated any points that have been raised through that work into the development of the app, for example, so that people can see the iterations that have taken place while the trial's evolving.
Great, thank you so much, Sandra. I have a question to ask you as well. I was wondering, you mentioned right at the end that you're working on prediction models for relapse, sort of with the aim of kind of more personalized intervention strategies. Could you say a bit more about that, please?
Yeah, sure. So this is a very new venture. So we have been fortunate enough to secure a grant from the Wellcome Trust to do this work. And so what we've found, or I guess our reflections over the past, many number of years that we've been doing this work, is while the systems for example, the digital remote monitoring systems or the self-management systems that we're developing are really good in some ways. The limitation is they're quite static. So when we're doing remote monitoring, for example, what we want to try and move towards is to be able to dynamically predict when somebody might be entering a clinical high-risk state. And so in order to do that, we need a data set that's of sufficient breadth and resolution and size to be able to develop reliable prediction models, so we can predict whether somebody might be relapsing for psychosis or not, or entering a well state. And that way, we don't have to just prompt people at a predefined alert system, for example. We don't have to prompt people once a day, every day for 3 months, for example, if someone's well. There's no point doing that. So we need to be able to learn when we want to prompt people digitally for more information and when we have sufficient information to make a decision. So our aim is to recruit a really large cohort of people with psychosis and ask people to monitor for a 12-month period, so quite a long time. And we're going to try and integrate active symptom monitoring with passively collected data to develop a dynamic prediction model that incorporates some machine learning techniques as well to see if we can predict relapse. And the ultimate aim of that really is, if we can do that, then we want to try and push out these ideas of the just-in-time adaptive interventions, which is a separate piece of work. But that way we'll be able to push out digital interventions at the time people need it, rather than at a predefined alert schedule, for example. So that's where we're wanting to take the work next.
Really exciting. Thank you so much. I guess a question for everyone. I was wondering what you felt, how much you thought that digital health interventions could kind of increase reach and access to groups and people that are less well served by traditional mental health services. So whether it be sort of Black and minority ethnic groups or those living in more rural areas. Does anyone have any thoughts?
I was waiting for Mario to kick in because I've always worked in Australia to those regions. So I'll let him go first.
I was waiting for you to come in and talk about your work as well, actually. Look, I think beyond Horizons, we've seen some of this now, particularly with the rollout of MOST. We see that services that are in rural and regional areas are particularly interested in the platform because they can see this as a way of improving continuity of care. But I think, for me, access is not only, accessing intervention, it's about how intensive the intervention can be for those who need the treatment as well. So we sort of have this hypothesis, right, that if you are able to increase intensity and continuity of care, that, for example, addressing the same target, it might be rumination or something like that in a more intensive way, we're going to be able to deliver more sort of stronger effect sizes for young people. Now, going back to, I suppose, regional areas, what we've seen in our samples is that, there are people from the regional community, there are people from rural and regional areas using the platform. And what we've seen so far is that the way they use it and the benefits that they derive from the platform are pretty similar to those in more sort of urban areas. But I know that Lucia has done work on that area as well with the minorities and all of that. So I'll let her go now.
Well, we know, unfortunately, that there is a shortage of people with the right training to deliver, the therapy. There are a lot of people who need it. So while digital therapy are probably not a substitute per se, if you are more unwell, they're probably something that you can add on to maybe reduce the waiting list or reach more people in a more effective way than just keeping them on a waiting list for a very long time. And then, yeah, there is also the fact that, of course, like Mario was saying, and Sandra and also Inez in her talk mentioned it as well, is a lot of the people we work with, of course, are people who used digital technology. They were born with it. So it's a medium that really speaks to them and they can engage with, and it's a medium that they look at first to find out more about what's going on in their life.
Maybe to add to that as well, I think in a way, digital technology in the way that we are developing that is also a way of delivering treatment early, especially for people, for example, with the intervention that we developed, people keep having access to the app. And so the idea is that they will not always use it, but they can start using it again whenever they feel more distressed or have the feeling that things are deteriorating. And in that sense, I think it also helps to provide treatment sooner, rather than having people to wait to see professional help again. So in that sense, I think it also reaches people at an earlier, or has a possibility for reaching people at an earlier stage, at moments when maybe things are not that bad already.
Thank you. Thanks so much. We've had a couple of questions come in. Ma Ruiz-Calafel says, thank you again, Lucia. I wonder whether you could give an example of a SMART goal from a participant in the study.
Yeah, surprisingly, for those of you who work in, the listeners who work in the clinic, they're nothing to do with symptoms. It's all around, I would like to be able to go and see my friends more often. I would like to, be able to visit my mum for her birthday. I would like to be able to go back to university or school or field. And also for some people who have struggled more, I would like to be able to go and buy my grocery on my own, because I still struggle to do that. So they're very, very, little things, but they can make a big difference to somebody's life. And the beauty of this scale, which you can download for free, is that enables you to quantify it. So there is a way of not just saying did you achieve it, but whether you partially achieved it, fully achieved it, or not achieved it at all, of course.
Yeah, interesting. I've not come across that scale. I'd be interested to look into it. Another one for you, Lucia, from Andrew Thompson. He says, fantastic talk, Lucia, and absolutely key to look at implementation. Did you look at the views of the treating team clinical staff about their clients taking part in the VR therapy and how they were able to support or supplement the treatment?
Yeah, it's a good question. I wonder, we're actually doing another study with in an inpatient unit at the moment with virtual reality for relaxation. And it's a bit of a divide. So there are people who really are enthusiastic about it and feel comfortable in offering it to the service user they work with, and people who feel a bit, intimidated by the technology. And I think a key is we spend quite a lot of time with the team showing the equipment, having them, having the possibility to try so that they know what it is like to use it before we offer it to the people they're looking after or they're working with. But there are some people who are just anti-digital technology and they require a little bit more convincing. Yeah.
Cool. Thank you. Inez, a question for you that came in from Swani Wirenga, who asks, CBT or ACT, that is the question, or both. Can you?
Yeah, I think, yeah, definitely. I think it very much depends on the individual. And I think probably both is well, at least in our trial, we tried not to do that, because basically you're doing something quite different. You're either saying, well, let's take a distance from these thoughts. You don't have to take them so seriously, accept that they're there, or you are trying to change the thoughts. So the stance that you take is a little bit different in both, and it's a bit difficult to do both at the same time. I think definitely what we saw in our trial is that ACT may be helpful for improving functioning and negative symptoms. Although, of course, we have to be very careful. It's just the first finding. It was it was a secondary aim, so it was not our primary outcome. Yeah, if we can replicate that finding, it would at least show that it may be helpful for people with more negative symptoms. But I think it's what I found interesting in our trial is at least to show that they're both equally effective in reducing psychotic distress. And so in that sense, I think it's just adding to the palette of possibilities and yeah, providing an additional way which will fit some people better than CBT, whereas for other people it will be the other way around.
Thank you, Inez. I'm not sure I can see any further questions, and we have a couple of minutes left. So I think I just want to give a massive thanks to you all for speaking today, and really fascinating range of different ways in which digital technologies have been used. So thank you once again. Thank you for those that have been listening into the presentations and asking questions. And I think, yeah, we'll call it.
Thank you, Charlotte, for organizing and sharing everything as well.
Pleasure.
Absolutely, definitely.
Thank you, Charlotte.
Thanks.